Okay, well, hello everybody, and thanks for having me. Sorry about the voice, I seem to have lost something to the lovely weather of Glasgow. I'm an MD PhD student from Odense University Hospital, and my speech is about the retinal oxygen saturation in patients with proliferative diabetic retinopathy, focal versus global changes after panretinal photocoagulation. So there's no commercial relationships associated with this study. A quick overview of today's topics. I'll give a short introduction, purpose, design, method, results, and then close with discussion and perspective. And Aina has covered this very good. The main force behind diabetic retinopathy or proliferative diabetic retinopathy is the increased hypoptic load. This releases the HIF and VEGF factors, which facilitates neovascularizations. As you can see on the picture, we have some neovascularizations here and here, a bit blurry on the last picture. This needs addressing, this needs treatment, so we treat it with panretinal photocoagulation. We know that this reduces the risk of severe visual loss for the patients with by 57%. So the idea with a laser treatment is that the laser energy delivered to the retina is transformed to thermic destruction of the retina, which lowers the hypoptic load, lowers release of HIF and VEGF, and thereby lowering neovascularizations or prevent progression of PDR or proliferative diabetic retinopathy. Purpose and the study. Well, the main purpose was to investigate the changes in the global and focal measurements in these patients before and 3 months after the intervention being laser treatment. So the design, it was a prospective interventional case control study. We had 26 patients, a 3-month follow-up. The intervention, as stated earlier, was panretinal photocoagulation with a Navila system. The examinations at baseline was wide field image. The activity of proliferative diabetic retinopathy were done with angiography, and the outcome, maybe most interesting part of it, done by measuring oximetry with a focal and global focus. I'll get back to that. Inclusion criteria, of course, they had to have proliferative diabetic retinopathy. Former panretinal photocoagulation was not allowed. Only one neovascularization on the retina were allowed. They were excluded if they had more than one neovascularization, if they had neovascularization of the disc, if they had any blurry interference of the optic media that could interfere with the images taken and the measurements done. They weren't allowed to have diabetic macular edema because we know that laser treatment of patients with diabetic macular edema could worsen it. If they were under 18 or if they were pregnant, they were excluded. So just a brief baseline of the characteristics: 26 patients, 18 were men, 8 women, around 53 years, duration of diabetes 21 years, HbF1c of 66 millimoles per mole. At Odense, the reference value is around 48 or below, so they were above. Systolic, diastolic blood pressure, and then the arterial and venous oxygen saturation measured at baseline, which concurs with earlier studies made on patients with proliferative diabetic retinopathy. Well, we needed to be sure that all the patients had proliferative diabetic retinopathy. So at baseline, we did an indirect ophthalmoscopy and a wide field image with Optus, as you can see on the picture. As you can see on the picture here, wide field image, just enlarged a bit, and right here we have a proliferation of just the red circle indicates that. The intervention the laser treatment with the Navilas 332 nanometer green laser. We did it in 2 sessions, 1 week apart, and of course the whole periphery of the retina was treated, as you can see with the pale dots all around on the retina. I have a small video, I hope it's going to work. Seeing it, the treatment with the Navila system is one of our patients in the cohort. It's fairly easy to use. And you can see that they have had the first session of PRP treatment done. Okay. So, the disease activity, it was done by looking at Optos fluorescent angiographies. We did the angiographies at baseline and at follow-up, and at the 3 months follow-up, we looked, of course, at the pictures and determined if there were any progression or regression of the state. And this was done subjectively as it is done in the normal clinic today. The area and the leakage of the neovascularization were the basis for this categorization into the 2 groups. So group 1 being progression, as you can see here at baseline, we have the neovascularization leakage here, and at follow-up it enlarges in area. And the regression group, group B, a neovascularization in the lower nasal quadrant. This got smaller at follow-up, so that was regression. The outcome oximetry measurements measured at baseline and follow-up by the Oximetry T1 system. The method was that we took macular-centered images. We chose one larger arterial and venous in each quadrant. The length of the segment that were measured had to be between 50 to 200 pixels in length. And just to say that I didn't measure 5 pixels from the optic disc edge and to where I start the measurements, just that I didn't start the measurements just at the optic disc edge. If the length of this segment was under 50 pixels before the first branch, a segment after first branching were chosen. So we did the oximetry measurements at the follow-up and baseline images. So one way of measuring oximetry results, 2 different ways to look at it. The first one, the global measurements, we took the mean of the arterial and venous oxygen saturation of all quadrants on the picture. So 4 arterioles summarized, divided by 4, and then the mean of all those 26 values. In the focal measurements, we only looked at the quadrant which contained a neovascularization, and the other 3 quadrants we didn't use the measurements there. So in the focal measurement group, we only have neovascularization quadrant measurements. Did a Wilcoxon and a Pearson squared test. There was this, a demographic overview, just to, again, looking at the 2 groups, progression and regression. 26 patients, 6 progressed, 20 regressed, just to show you that there weren't any differences between the 2 groups, only when we looked at sex. And here we also looked at the laser spots giving in total and laser energy delivered to the retina in total. Looking at the arterial changes in retinal oxygen saturation in the global measurements, I've just pointed out the 2 groups, progression group, regression group, and the mean values for baseline and follow-up, and then a delta value, just the difference from baseline subtracted from follow-up, and the mean of that. So we can see in the global measurements, we can't see any difference between the two groups. But in the focal measurements, we have statistically significant value here. So it was able to detect a difference. If you look at the venous, we have the same picture, maybe a small trend on the global side, and the same trend here, or the same statistically significant value at the focal. And perspective, just to see what did these results show us. Well, if we look at the focal measurements, a development in the arterial or venous oxygen saturations 3 months after, if there were a positive change or an increase in oxygen saturation, that predicted progression of PDR. And if it were a negative change or decrease, it predicted regression of PDR. If we had to be strict, the global measurements didn't show us anything, a small trend, that was all. So, an explanation could be that the POP treatment that are given actually allows the oxygen to leave the vessels and go out to the tissue where it's needed. Perspective could say that the focal changes of oxygen saturation could be a potential biomarker for disease activity in patients with PDR, proliferative diabetic retinopathy. But of course, a larger cohort is needed and longer follow-up are needed. The strength and limitations of this study. The strength is a very homogeneous cohort, only one neovascularization, only one quadrant. Oximetry and angiographies were made at baseline and follow-up. We used the Navilas system, not saying that the Navilas system is any better or that I have any thing to do with Navilas, but it's just that it made it able to see the energy delivered to the retina, and we could see if there were any difference between the two groups on that. The limitations, of course, number of patients, 26 patients is not a lot. If I could have had 100, that would be great. But Denmark is too small in Odense. And 3 months follow-up, 6 months follow-up could be good, and it's in the tube right now. Acknowledgement, just want to say thanks to my main supervisor Jakob Rauslund and supervisor Tone Petro. Funding was done from the Velux Foundation and the region of Southern Denmark. Thank you very much.
Thank you very much.